Your postcode might be a more powerful predictor of your health than your own genetics. That's a chilling thought, but a shocking new data release from England's National Health Service has just confirmed a grim reality. Where you live directly impacts how long you will suffer in pain while waiting for essential medical treatment. A postcode lottery of health, hiding in plain sight, has now been officially exposed. Today, we're pulling back the curtain on this explosive new information. For the very first time, the NHS is revealing the granular details of its waiting lists in the east of England, and the picture it paints is deeply uncomfortable, challenging the very core of what the health service is supposed to stand for: universal care based on need, not wealth. In this investigation, we'll uncover the staggering numbers that prove just how wide the gap is between the richest and poorest communities. We'll explore why the government's own health secretary is candidly calling this data release a powerful disinfectant for a system he admits has been neglected for years. And most critically, we will ask the multi-billion-pound question: is this a genuine turning point for fairness in healthcare, or is it just more data and more promises for a public that has grown tired of waiting? Let's get into the details. The headline finding is as stark as it is simple. The NHS has published data broken down by what is known as the Index of Multiple Deprivation, or IMD. This is a government measure that ranks every neighbourhood in England from the most deprived to the least deprived. What the data for the east of England shows is that patients from the poorest communities, those ranked as IMD 1, are demonstrably more likely to be stuck on waiting lists for longer than 18 weeks. The exact figure is 46.9%. Nearly half of all patients in the most deprived areas are waiting beyond the target time. Now, compare that to those living in the most affluent areas, ranked IMD 10. For them, the figure is 43%. While a difference of 3.9 percentage points might seem abstract, let's ground this in reality. This isn't just a statistical anomaly. It is a chasm of human suffering. In a region of millions, this translates to thousands of individuals whose lives are put on hold. Think of the retired factory worker in a coastal town waiting for a hip replacement. For him, every extra week on the list is another week of chronic pain, another week of lost independence, another week confined to his home, watching the world from a window. His social life dwindles, his mental health suffers, and the risk of a debilitating fall increases. The burden then ripples outwards, falling upon family members who may have to reduce their own working hours to provide care, putting further strain on already precarious household finances. Think of the single mother needing gynecological surgery. The longer she waits, the more her condition impacts her ability to work and care for her children. It is a vicious cycle where poor health and poverty feed each other, perpetuated by a system that is failing those who need it most. This data confirms that for thousands, the promise of the NHS is being deferred, and justice delayed is justice denied. Jatinder Garcha, the Director of Commissioning of Public Health for the NHS in the East of England, put it plainly. The East of England is made up of a diverse population living in a variety of coastal, rural, and urban areas. Identifying and understanding patient demographics is vital if we are to address the inequalities in access and quality of care that we know exist. This acknowledgement goes far beyond simple geography. The inequalities in access that Garcha mentions are a complex web of socioeconomic barriers. It's not just about a lack of transport. It's about health literacy, the ability to understand complex medical information, to navigate the bureaucracy of referrals, or to feel confident enough to ask a consultant critical questions. For someone who struggled at school, a dense, jargon-filled appointment letter can be as intimidating as a locked door. It's about the digital divide. As the NHS pushes more services online through its app, it risks leaving behind an entire segment of the population, often older, poorer, and less digitally savvy, who lack a smartphone, reliable internet, or the skills to use them. And critically, it's about the nature of work in deprived communities. Someone on a 0-hour contract cannot simply inform their boss they need a day off for a hospital appointment in another city. The choice between attending an appointment and losing a day's pay is no choice at all for a family on the breadline. These are the insidious, everyday hurdles that this new data forces us to confront. For years, campaigners and patients have spoken of a two-tier system, but it was often dismissed as anecdotal. Now, the NHS itself has provided the evidence. This move towards transparency is part of a wider government strategy, the Elective Care Reform Plan, which promises to make the National Health Service the most transparent health system in the world. And the language being used by those at the top is unusually blunt. The Health and Social Care Secretary, Wes Streeting, said, "We inherited an NHS which after years of neglect had left all patients worse off, but some more than others." He continued with a powerful metaphor. Sunlight is the best disinfectant. Only by being upfront and shining a light on inequalities can we begin to tackle the problem. This is a remarkable statement. It's a political acknowledgement that the system is not just overwhelmed, but fundamentally unfair in how it distributes care, and that the first step to fixing it is radical honesty. It's a powerful and frankly worrying reality, seeing the scale of the problem laid out in black and white. If you believe that transparency like this is the essential first step towards building a fairer health service for everyone, regardless of their background, take a moment to hit that like button to show your support. The human impact of these waiting times cannot be overstated. We are not just talking about numbers on a spreadsheet, we are talking about people's lives. Sharon Brennan from the patient advocacy group National Voices highlighted this perfectly. She stated that by understanding who is waiting longer, trusts can take real, tangible actions. She said this might be as simple as offering to help people get to appointments, or ensuring people understand that they have choice over where to be treated. This gets to the heart of the issue. By being honest about the impact, Brennan says, the NHS can begin winning back the trust of communities who often feel unheard and sometimes unwanted. This feeling of being unwanted is particularly acute in certain areas of medicine. Professor Ronnie Thakkar, president of the Royal College of Obstetrics and Gynecologists, has called this a postcode lottery in gynecology care. She warns that for women in the most deprived areas, the long waits are not just an inconvenience. In her words, delays can lead to a need for more complex treatment and significantly impact women's health, well-being, and daily lives. This threatens to entrench existing health inequalities even further. Imagine a woman suffering from a condition like endometriosis, where every month of delay means more pain and potential long-term damage. Now imagine she lives in an area where she is statistically more likely to face that delay. This isn't just a system failure, it's a gender and class issue rolled into one. So, with the problem so clearly defined, what is the proposed solution? The government isn't just publishing data, it's launching a multi-pronged attack under its 10-year health plan and a new plan for change. The central promise is to tackle these health inequalities head-on, by diverting billions of pounds of funding away from other areas and directly into working class and deprived communities. One of the flagship policies is the rollout of new neighborhood health centers. The key here is that they will be targeted first at the places where healthy life expectancy is lowest, specifically mentioning deindustrialized cities and struggling coastal towns. The idea is to bring healthcare to the people, rather than expecting them to navigate a complex and often distant system. The vision for these neighborhood health centers is ambitious. They are intended to be more than just glorified GP practices. The goal is to create genuine community health hubs, places where you can get blood tests, diagnostic scans, physiotherapy, mental health support, and advice on diet and exercise, all under one roof. By placing these facilities in the heart of the communities they serve, the plan aims to break down those practical barriers of travel and time. More importantly, it seeks to build trust. A local center, staffed by people who understand the community's unique challenges, can engage in proactive and preventative healthcare, tackling problems before they escalate into conditions requiring a long wait on a surgical list. The economic argument underpinning this is powerful. The government's own figures estimate the cost of sickness-related economic inactivity at a staggering 240 to 330 billion pounds per year. Investing a few billion in targeted preventative care in the places that need it most is presented not as a cost, but as a sound investment in the nation's economic productivity and long-term health resilience. It's a shift from a reactive sickness service to a proactive health service, a change in philosophy that is long overdue. Beyond infrastructure, there's a plan to tackle the root causes. The government is investing £5 million to recruit 1,000 people from groups and areas hit hardest by unemployment directly onto the NHS career ladder. It's a strategy designed to address both economic inactivity and health inequality simultaneously, creating a workforce that better reflects the communities it serves. Officials point to recent national successes as proof of momentum, claiming to have delivered over 4.6 million extra elective care appointments and over 6.5 million extra diagnostic tests, while cutting the overall waiting list in England by over 260,000 since July of 2024. But here's the critical question. Are these grand plans and national statistics enough to reverse what is clearly a deep-rooted systemic problem? The responsibility for turning this data into action now falls squarely on the shoulders of local NHS providers. They are being explicitly asked to analyze this data, to understand the unique inequalities on their own waiting lists, and to build evidence-based plans to address them. They are being told to put these inequalities at the very heart of their efforts to cut waiting lists. It's also worth noting the nuances and limitations of this new data. In its current form, each demographic breakdown is independent. However, it cannot yet show you the intersection of those two categories, the number of women from deprived areas who are waiting. This limitation of the data is more than a technical footnote. It's a critical blind spot. The concept of intersectionality is vital here. The barriers faced by a white working-class man waiting for a knee operation are different from those faced by a woman from a South Asian background living in the same deprived area who needs treatment for a gynecological issue. She may face not only the challenges of poverty and poor transport, but also potential language barriers, cultural stigmas around her health condition, and a system that has historically failed to adequately address the health needs of minority ethnic women. Without data that captures these overlapping identities, any interventions risk being too generic. Targeting deprived areas is a start, but true equity requires a much more nuanced approach that understands how class, gender, ethnicity, and disability intersect to create unique and profound disadvantages. The NHS's commitment to transparency must evolve to include this deeper level of analysis if it is to truly serve all the people all the time. Despite this, the move is a seismic shift towards transparency. Daniel Elkelis, the chief executive of NHS Providers, which represents hospital trusts, called the breakdown of waiting list figures a welcome, much-needed step to help NHS trusts identify and tackle deep-rooted differences. So the data is out. The problem is exposed in undeniable detail, and a plan has been announced. The real test begins now, not in the press releases from Lighthall, but in the hospitals, clinics, and new neighborhood health centers across the east of England and, eventually, the entire country. Will this data be the catalyst for genuine, life-altering change, or will it become just another report, another set of statistics gathering dust on a shelf while the postcode lottery continues? We will be following this story very closely because its outcome affects millions. To make sure you don't miss our updates on this and other critical social issues that affect us all, make sure you are subscribed to the channel and have those notifications turned on. It's the best way to stay informed as we track whether these promises are kept. Ultimately, this story is about more than just numbers. It's about a fundamental promise that lies at the heart of the National Health Service, a promise made nearly 80 years ago, that the care you receive should depend solely on your medical need, not on the size of your bank account, your ethnicity, or the street you happen to live on. With this new era of transparency, we, the public, can finally hold the system to that promise. The sunlight is in. Now it's time to see if it really can disinfect a system in need of healing itself.